Hello and welcome to Recovery Stories Have Power. My name is Oliver Books. This is the third episode in a series of video podcasts we filmed at Faces and Voices of Recovery's annual Recovery Leadership Summit in Denver, Colorado. On today's episode, I had a conversation with Dr. Corrie Vilsaint. Dr. Vilsaint is a recovery scientist who serves as an instructor at Harvard Medical School, Associate Director of Recovery Health Equity at the Recovery Research Institute, and Research Scientist at the Center for Addiction Medicine. During our chat, we covered the science behind recovery community centers, disparities in outcomes in traditional treatment settings, and efficacy of community-based supports. And now, Dr. Corrie Vilsaint. Let's get into it. Thank you, Dr. Vilsaint, for joining us on Recovery Stories Have Power today. Could you introduce yourself to our audience and tell us a little bit about what you do, who you are?
Yeah, absolutely. I'm so happy to be here. Thank you for inviting me, Oliver. Yeah. My name's Dr. Corrie Vilsaint. I am trained as a community psychologist. I'm instructor at Harvard Medical School, and I also serve as Associate Director of Recovery Health Equity at the Recovery Research Institute. And so if anybody should need to find me online, recoveryanswers.org has my bio up there and contact information. So
Excellent. So how did you, going all the way to the beginning, how did you start in a recovery field? What led you into this work?
Well, yeah, I'll tell you, it's kind of a leap of faith at some point in time, really. It's kind of a leap of faith, you know. I decided that I did want to use the path of psychology to study drugs. And I was also very interested in the intersection of race with drugs as well. But, you know, you go to school and they offer you certain chunks at different times, you know. And it was like, well, the treatment field was well established. Prevention field was well established, but I really didn't know until I left and went on to my first job that you could actually be a recovery scientist, and that recovery had a seat at the table as well. Yeah. And so it was by finding the Recovery Research Institute that I did that. And I realized you don't have to be a clinician to work in recovery. You didn't just have to be a biostatistician, but really it kind of recovery gives us a place that we all get to work and kind of have a seat at the table. So it's kind of a leap of faith, and then realizing, yeah, people are working and there's a place here for recovery and recovery science.
That's amazing. So what was the deciding factor between a more recovery community center oriented thing or recovery oriented thing versus that traditional treatment outlook? Clearly the treatment has been around for a long time. I think it sounds like a lot of what we're doing and seeing right now is a little bit newer. It's a little bit of the Wild West, it seems like.
Yeah.
But yeah, what was the pull there?
You know, early on I decided I wanted to interview, and I did for both clinical psychology and community psychology. After I did that, though, I was really drawn to the idea of a field that was based around empowerment. It was based around health and, yeah, sometimes even fighting for the underdog. And, you know, therefore it was community psychology that really drew me in at the end of the day. And treatment, which we rely upon and have important work going on there, that's, you know, something that has a bit of a different orientation approach, right, with certain pathology, symptomology, treatment, and diagnosis. But I was really drawn to the community-based approaches and how do we work with our communities to promote health. And I think that's probably when I decided that I would go that route.
Excellent. Yeah, absolutely. And so you have had a very busy month. We're at the Recovery Leadership Summit now, and you just walked off your keynote. Yeah. So thank you for being here. and you were at Boots on the Ground just, was that in May?
Yeah.
And I've heard you talk a lot about recovery capital as a strength-based approach versus pathologizing substance use disorder. So that's so big that I think just the both in terms of stigma, how we treat people differently across race and class divides, how we approach addiction as a society. So for our listeners, can you take a very high level overview of like what that strength-based versus pathological approach, like what are the differences and what does
Yeah.
that look like, and what draws you to specifically the strength-based recovery capital
I would
side?
love to. Right, absolutely. So when we talk about recovery capital, we're really, in theory, we're talking about all of the assets and resources, the sum total that's needed to initiate and sustain recovery. Recovery capital is found in our policies. It is found in our social networks. It's found within our individual recovery motivations, our intelligence. Those are all things that we bring to the table when we're talking about recovery capital. And recovery capital has helped to change the narrative a bit, meaning we were dominated by the medical field, but recovery is becoming more validated and accepted among scientific, medical, and even government communities. And so recovery capital kind of it's different in that there is this focus of strength, right? We were looking at negative drug screens as an outcome. We were looking at reductions in substance use and maybe even remission. But we know with recovery, it's more than the absence of something. It's about the presence of something. It's about the presence of health, the presence of well-being. And by adding recovery capital, the recovery field kind of picking this and adding this, we're changing the narrative on what it means to be in recovery, look like what it's in recovery, and as well as the process by which it's achieved, right? And so it's becoming, as it's becoming more accepted and validated, we're now having a larger framework. It's becoming more strength-based. We're not just looking at what's broken. We're looking at what works. We're not looking at just what is unadaptive, but we're looking at what is adaptive as well. We're moving from just talking about remission to talking about resilience and recovery, right? And more so just even disease versus health. Right. We've added that to the conversation. That's something that this recovery movement and recovery capital has helped to do.
Yeah, that's amazing. That's amazing. So taking the strength-based recovery approach and the community psychology approach, we had talked a little bit via email before this. Tell me a little bit about the science behind recovery community centers.
Oh, yeah, absolutely.
Yeah.
I would love to. Boy, there was a lot of work to be done with recovery community centers because the world did not always know what they were.
Sure.
Right? So before we even jump into what are outcomes and what's going on with outcomes, we need evidence to describe to us, what are these? What services are they providing? Where are they located? How many are there? How are they structured? How are they funded? These are all part of our science that had to take place to lay the foundation so that the world could know about this model. Mm-hmm. Of course, we want to know about the efficacy of recovery community centers. We want to know about the efficacy of anything that might have the potential to benefit people in recovery. And so the science has started to emerge, right? Sure. I can tell you that the first pass that we had at the Recovery Research Institute, we studied a group of about 32 recovery community centers across the New England and New York area. Everybody in that study was using a recovery community center. So that is a limitation of that study design, but we still learned a lot. We interviewed the directors, we understood the services that they do, and we understand their approach to doing things. This is not a clinical approach, right? It's not a top-down, it's a bottom-up. Right? Getting all those things documented. And we were seeing that these recovery community centers are helping people in a unique way that not even necessarily sometimes our 12-step meetings are helping people in this way. Some of the mechanisms that were at play here were different with this. And ultimately, they're building quality of life, they're building self-esteem, and they're increasing people's recovery capital. Yeah. Right? And they're doing so in such a way that often, sometimes these resources are not always available to us in maybe a traditional treatment center. Sure. And so not only are they out there and they're working, but they appear to be tapping things that other resources may not always be able to tap. So right now, though, we're currently doing a study to take it to the next level, right? So I told you that we studied a group of everybody, 335 people who were using recovery community centers, and we followed them up longitudinally for 3 months. Now, the thing is we don't have a comparison group. And in science, we are always wanting to know what's the cause of something. Well, how do we get to the bottom of that? You don't know the cause of anything if you don't have a comparison group. So right now, what we're doing is we're studying people in early recovery who use recovery community centers, and also people in early recovery who do not use recovery community centers. This is an ongoing study. We won't be done with it anytime in the next week. Let's put it that way. Sure. Okay. But when we do, we're going to start to have some of that causal evidence to bring to the table. One of the big hypotheses and the interesting things that came from our research from recovery community centers that motivates this study is that we know that it takes about 15 years before quality of life for somebody in recovery returns to that of the general population and somebody who didn't have a substance use disorder. It takes 15 years. That's too long.
Yeah.
But in our study of people who were using recovery community centers, they were hitting that level of quality of life at 5 years in recovery. Wow. Imagine being able to accelerate the recovery process, right? Yeah. Isn't that quite a vision? But in order to really draw firm conclusions and know if that's what's happening, then we have to amp up our study design and go in again. So that's what we're doing.
Sure. Test and retest.
That's exactly right. But isn't that some exciting hypothesis?
That's amazing.
That's amazing.
That's by a multiple of 3 times, just the speed at which someone could re-enter society and build these full. And at the Recovery Leadership Summit, it's such a treat to be here because we see all of these advocates and all of these folks who are just in this field. And I would go out on a limb and say most of them are in recovery living these really incredible lives.
Yes.
It's just the energy in this room to just see kind of just what you're describing, this acceleration through community efforts to build these better systems and help people live the lives that they were, the best lives that they were meant to.
Exactly right. Because when people in recovery know once you get a taste of what the lifestyle can bring to you, right? Then you don't want to let it go and you want to recreate it for other people.
Absolutely.
Yeah.
Absolutely. So, with these community-oriented systems of care, you talk a lot about racial disparities in outcomes as far as substance use goes. What are some of the strengths that you're finding in terms of community-based systems of care? That was something I was really drawn to with your work.
Yeah, absolutely. We do have pretty clear-cut racial disparities in substance use disorders. We could just start by saying right off the bat, we know that people who are Black or Latinx are half as likely to remit from a substance use disorder. Okay. This is happening for a number of reasons, but in terms of what the science tells us why it's happening, those are mechanisms of health disparities. How can recovery community centers play a role in that? They're like the Amazon shopping of recovery. They have so much freedom in the way that they choose to shape and serve people. And part of the science is telling us that these health inequities, they're coming down through structural mechanisms. It's showing up in people's jobs, that they're not getting promoted at the same rate, that they might not have access to jobs. We're learning that people of color in recovery are more likely to be denied housing because people know about their history with alcohol and other drug use. So if we are learning about these things, part of what we can learn, and then of course there's over-involvement in the criminal justice system, that they're over-policed and over-involved in the criminal justice system. What does this mean for recovery community centers? What this means for recovery community centers is one of the focuses that they can work on is, and I've heard about this happening out in California even, building relationships with people, sometimes even lawyers, who have the ability, pro bono relationships sometimes, have the ability to help clean up somebody's record. Okay, that's a way of addressing health disparities right there, because their records are more likely to be marked, right? Helping to get linkages to employment, because we see clear-cut health disparities coming through that type of mechanism, not only their employment, but also their ability to get promoted. And so having that be part of your system of relationships that you develop around town, learning about recovery-friendly employers, right? Yes. These are how we start to connect the dots from what we learn about how health inequities are created to, but what does that mean for me? And then there's even things about being open to certain harm reduction services. Yeah. That's a form of equity right there.
Sure.
Right? Sure. That's a form of equity.
Yeah, absolutely.
And it is, I tell you, recovery community centers, you'll see, they don't shy away from those things. They don't shy away from maybe providing wound care, right? Or linking people to services. And I think that something like that is a form of equity as well.
Absolutely.
Yeah.
Absolutely. It is an absolute treat to hear your passion behind the this type of approach to care. It's clear in just how you're talking about it right now that you care deeply about these systems and these people, and I just want to say personally, like, thank you for doing the work that you're doing. That's amazing.
Thank you for taking the time that we can share this with people. That's right.
Absolutely.
Yes, that's right.
So we know that recovery community centers are a fantastic method for a boots on the ground approach to care.
Yes.
No pun intended.
That's right. I like it. I like it.
So how can we improve these systems? I think it seems like it's a relatively new approach. So what are some of the early barriers that we're seeing? What are some of the early successes? I mean, you've dove into some successes so far.
Yeah, no, I would love to talk about that. When it comes to recovery community centers, some of the barriers that they face, one way I think that could help them is going to be using measurement informed care. So what are we talking about with this? Our directors, they need to get some feedback, and they need to get some feedback regarding sometimes who they're serving, what services are most popular that people are using, and they need to get feedback whenever they innovate. The people, the directors and the staff, they're going to innovate new ideas there, right? And they need to get feedback on how it's received, right? And things along that line. And that's why, like in Massachusetts, we've been working with our PRS, they call them peer recovery support centers there. Yes. We've been working with our PRCs because not only are we designing a quick, brief evaluation system that won't get broken in the process, meaning don't just take this data and give it to the state so they can pass it up, but this data is going to come back to you in a meaningful way, right? And it would be ideal if they even have dashboards. Okay.
Sure.
So, because when you don't get the information back, you start laboring over it and it starts to break the system, right? Yeah. So one, it needs to be quick. It needs to be easy. It can't be a 3-hour assessment. You got to get people in and out in 15 minutes, right?
Totally.
And then we got to keep this information link cycling back to the center. So we're thinking about, and working on how can we get instant feedback. These people need dashboards, you know what I mean? Not only to see what's going on today, but think about what happened a year ago, right? So they can compare, right? So giving them meaningful feedback on the work that they're doing, not just to report to an evaluator for the grant. And the beauty of recovery community centers, as we're working and developing this, you could take one or two of the questions that we ask these people, and they would take a community meeting and have a whole meeting around it. Sure. These people will work with what you give them if you give them that information.
Sure.
They're very active in their communities and in their community meetings and how they choose to run these organizations. So they will use this information, from the top down. But I think that's one way that we could better service these organizations, Additionally, I also think that, for example, in Massachusetts, they have supervisors, meaning sometimes they rely on or are part of, in some capacity, maybe another agency. Maybe it's a treatment organization or something like that. And we call them their supervisors. Supervisors actually can play a critical role in the way a recovery community center operates. And if it's actually community driven, if it's going to thrive, or if it's going to be inadvertently stifled because people are unfamiliar or micromanaged in the process. And it can be unintentional, but when folks are coming from that clinical background, and I work at a hospital, I'm familiar, you know what I mean? I'm familiar with that. We're used to very top-down management style approaches, clear protocol, structured directives, we work with insurance, but this model flips all that on its head to a degree. It's free. You have to be ready for people to walk in the door, right?
Sure.
And you have to be willing to work with people from other programs, not just maybe one from your parent organization who's getting treatment there, but rather anybody on that continuum of care. So opening and welcoming to even family, right? Or the other people that might be in this person's lives. And so I think that identifying barriers and how to turn them into facilitators, it's good for us to give education to our supervisors about this very new model, that they're not used to seeing, and how they can support these organizations with making sure that conflicts don't conflict with the larger agency. That's how you support them. Help them guide their budget, right? That's how you support them. Advise them when common issues arrive around ethics, boundaries, right? That's how you support them at that level. But, you want to caution against running it like an outpatient treatment center.
Yes.
Like in a traditional, there's peer choice here. And we don't want to have too much clinical data collection going on here, because it reduces the community buy-in and that inspired the volunteerism and the participation. And so I think that taking that and providing education to our supervisors who want to support us and helping them know how that they can do that along the way, and also showing them some of those cool recovery data so they understand the big vision of what we're doing here.
Totally.
Yeah.
Totally. So perhaps what I'm hearing is there's a level of consistency across these community centers that might be less present than something as structured as that goes back as far as like a treatment center. And even those don't have too much in terms of consistency. So, I mean, this recovery thing, as was said earlier, it seems like there's a lot happening all at once. What is your vision for a consistency across recovery community organizations?
Yeah, the consistency, I want it to be, it should be in the process.
Yeah.
It should be in the process. In Massachusetts, even the name of their recovery community center is decided by the people who use it.
Sure.
Okay. And so that, I think, keeping that consistency and then allowing us to continue to provide them with useful data, analyze the data so they can get information on how to continue to innovate and best help people. These directors, I tell you, they're asking innovative questions. When I tell them about, let's say, what we know about quality of life, but yet we know people in recovery community centers are hitting that at 5 years. Is that causing it? They're on the next question. They say, I need to know what services are linking to improving their quality of life. We don't know that yet.
Right, sure.
Okay, you come be a part of the science team, because what we need to consistently do is provide them with feedback about what they're doing and help to measure their innovation and keep that, like I said, it's not a top-down, it's a bottom-up approach. It's an organic approach, and keeping that fundamental base to it. That's how you fill a gap on the continuum of care that is not filled right now. That's not going on anywhere.
Yeah, absolutely. Absolutely. Talking about that gap, I think you speak a lot to the strength of that community care in terms of filling a need in racial disparities that exist in more traditional treatment avenues. So can you speak more to that? Folks who identify as Black and Latinx having significantly higher strength-based success than punitive.
Oh, yeah, absolutely. And I'll tell you, that's not the first time we've seen people of color have higher scores on what you might call well-being opposed to diagnostic assessments.
Sure.
If we look over at our history over in mental health, we could see that as they had a number of diagnostic assessments they would run and a few well-being indicators, we learned kind of early on that sometimes they score higher and report higher scores and are reporting doing fairly well on these well-being type indicators. So that's not uncommon there. The focus that we need to have when it comes to those inequities is going to be what it is that they are disproportionately exposed to. Sometimes they're called social determinants of health. I think they're more social political determinants of health.
Sure.
That's causing them to be half as likely to remit, or that's causing their overdose rates to be fastest increasing in those groups right now, which is a change in recent history. We know that this is driven by the criminal justice system, and that they are far more likely to be pulled into that criminal justice system while not necessarily using drugs at any higher rates. And so we know that that has a piece of it. And we also know that there's huge healthcare disparities when you do go into treatment. It's becoming well documented at this point that, for example, buprenorphine, life-saving medication. We know now, though, that when people show up for care for an opioid-related event, there's a low chance that you'll be getting that. Only about 23% of individuals who are white get that, and it's half the rate for Black people. And they have, in our studies show they have the exact same number of visits. Latinx is about white individuals, about 23%. Latinx is coming in about 20%.
Okay.
We're getting offered. So you see it kind of, there's a continuum there that's happening. And unfortunately, so healthcare disparities is also part of creating that. And unfortunately, I would have to tell you that when it comes to co-prescribing naloxone, which is overdose prevention, those trends are mimicked. Again, and so the concern with that is that the communities where we're seeing overdose rates rising the fastest are the least likely to be prescribed naloxone. Furthermore, they are the least likely to be offered buprenorphine compared to methadone. Why does that matter, right? If you're a person who's using medication along the way, why does that matter? Methadone is high barrier. You often have to go to the clinic every day. Part of the requirements might be that you involve yourself in counseling. We know on average it's a 20-minute drive both ways. So you got to think how does that affect somebody's life? Right. How does that affect somebody's life? Buprenorphine came on the scene. You can take this medication in the comfort of your own home. And it can be formulated with overdose protection, unlike methadone. Sure. But we know that we're offering methadone to people of color more often, and we're offering the buprenorphine to both higher income and individuals that identify as white, right? So we ended up with this segregated treatment system somewhere along the way. And so that's something that people, depending on what city you're in, you need to look out for that, because sometimes it's happening more in other cities, than others. But that's why we have these health inequities. It's going to be the criminal justice system. It's going to be healthcare disparities. But then we look to our recovery community centers and these community-based. The first thing that we are hoping right off the bat is, how can this be a tool of equity? Because you work in their community. You go into the places where people live, eat, sleep, work, play. Getting all the way into a healthcare system can be a hike. So the fact that you're in their communities, right there, reaching them, going into their communities. Another way that we're hoping that recovery community centers, and some have already started doing this, is we know they're experts at training peers, right? They're expert at training peers, and they have expertise in how to deploy them in certain settings and reel them back in to give them the support and the training that they need.
Absolutely.
Sending them into the criminal justice system is something that we're learning, right? So if that's a mechanism of health inequity, we now have early models showing us how peers can go in and be a part of the reentry planning process. And they're laying a whole new groundwork and orientation for people who are coming out. For example, introducing them to the recovery ecosystem. When they're getting ready to come out, sure, they may have heard of halfway houses and they're thinking that they might do that. But have you heard of recovery housing? Do you know what a sober house is? Right? That's a way you start to connect people with the recovery ecosystem. In part of the reentry planning is, now we know how we can actually use peers in forensic settings to start that planning process. There's great evidence and studies coming out of Virginia showing how you can use that model and how it helps reduce inequities. Right? And so we're counting on recovery community centers to be able to do that. Courtroom setting, right? It doesn't have to be just behind bars, the courtroom setting. We're hearing from judges how useful it can be when their peer coach shows up with them. Shows up with them. These are tools of inequity, and those peers, we hear people, well, I'll listen to the expert. They're talking about the peer, right? They're talking about the peer in court. So the peer can talk about what they've seen, what progress has been made, what they need the judge to help with so they can continue to move forward. We're seeing peers used in court as well, right? And so that's another way that these recovery community centers can use their expertise in training peers to help reduce, health inequities as well.
So you've talked about a number of systems in our conversation here. I'm going to pull from your keynote earlier. Someone had asked a question about insurance and this strength-based versus pathologizing kind of flips that on its head. And I thought you had some really great points about that. Can you elaborate on that for us?
Yeah, absolutely. So how do you get third-party payers involved, right? When you start a new system like recovery community centers, where does the money come from? Like I said, in Massachusetts, our state funds these centers. That's not going to be the norm, though,
Sure.
right? So what do you do, regarding everybody else? So that kind of brings us back to our recovery capital conversation. And insurance companies, they're used to working in a clinical environment, right? And we're working with certain outcomes, certain diagnoses, etc. But part of what the recovery movement has offered is this concept of recovery capital. And it is indeed catching on. And we are seeing it show up in Medicaid. Okay. So there are some states now where the directors of Medicaid are requiring a recovery capital assessment because they are realizing and getting behind the idea that we need to get people assets and resources. This is good because when the ASAM, the American Society of Addiction Medicine placement criteria, most widely used placement criteria for addiction settings, recently brought in recovery capital. That's the bridge to recovery support services.
Yes.
They want now our treatment system to get familiar with recovery support services, bridge them to those services under the idea of we're going to take care of pathology and symptomology, and we are going to want some more help along certain points along the continuum of care, and we're going to want people to get assets and resources that they need to get their foot back into the door. So you see it's starting to become formalized, right? And there might be the day where insurance companies now actually require the doctors to do a recovery capital assessment. But that's how the recovery capital and the recovery movement and the third-party payers, start to become involved in this, and that they are interested in getting people assets and resources now that we understand and identify that this is a part of the recovery process. It can help them with their trajectories. It can buffer against these post-acute withdrawal symptoms and the things that happen when you try to get when you are straining to get comfortable with abstinence, right? And so we're starting to put all this together in our studies and our science and even some of our animal models, right? And even some of our animal models showing how sources of capital mean that animals take different routes when they're exposed to drugs, right? And that's how we start the science there and continue to grow it. So.
Is that Johan Hari Rat Park example?
The rat park.
I love
classic
that.
example. That's right.
A very close friend of mine. Is it time for rat time? It's time for rat time. So that's just kind of part of my little personal recovery journey is a lot of rat time.
A lot of rat time.
Oh, that's amazing. And it seems so, I mean, I guess from me personally, my perspective, it seems clear that there's a lot of early research indicating that these systems of recovery capital are functional. Like it's helping people live good lives. Hopefully we can keep on this route and get everyone along the continuum of care on the same page going forward. I mean, it sounds like we're starting to, maybe.
Right.
A little bit.
Exactly. That's critically important, because one part of what we just talked about earlier is that we have a treatment infrastructure that we have gotten very good at certain points, right? We've got pretty good at medical detoxification and managing that. We understand that we're going to get them to a clinical brief episodic treatment, right? Clinical stabilization. We're getting that and figuring that out. But we also know that even in the research, the average length of clinical trials is 12 weeks. But what we just talked about earlier today is that recovery vital signs tend to actually dip around 6 months or 1 year, meaning their self-esteem, their quality of life, happiness, right? It actually dips. So that's not consistent with a 12-week treatment model, is it? Right? So we need to learn to build an infrastructure that maps onto what we are learning about course of illness.
Yeah.
This is why we are going to be relying on our recovery support services to extend and diversify the continuum of care. We need to be able to attract and engage new people, young people, people who have developed medical mistrust and will not engage with the healthcare system, right? We need to find different ways of getting to them, and this is what recovery support services are going to be able to do. Not only help with what we understand about course of illness and recovery, and recovery vital signs dipping at certain times, but also a desperate need to get different people who are willing to engage in the system, right? Yeah.
It is a big task, but it seems an exciting one.
Yes, that's right.
That's in talking. I had a thought, and that's you spoke about young people and getting more people involved in this gestures broadly for our audio only listeners. And I wonder if you could say something to the perhaps younger folks who are interested in maybe joining recovery in some professional sense, whether it is through psychology or just being a peer themselves.
Yeah.
What advice would you give to them? How would you help direct them into some of these really exciting ideas that we're discovering?
Oh, absolutely. Right. Learn about this recovery ecosystem. It's not just about 12-step models anymore. That's not what we're doing here. My goodness, we have entire wellness centers and gyms, places where you can go, whether it's that you can go that are recovery based now. We are learning to design systems that will attract people of different ages and have different interest. Right? Because it's the evidence is clear how helpful AA was, but at the same time, look at the average age of folks who go to AA, right? And so that's not necessarily going to link us in to the younger group who are also trying to attract all the time, and so if you maybe right now you don't feel like you want to sit around and talk with people about your recovery, you want to hit the gym with other people in recovery. We've got recovery support services for that, right?
Yeah.
So learn about that. We have collegiate recovery programs for our youth now, right? This is another model that we're running, again, to engage and attract, and they are coming up with all different ideas of what their identity as an organization wants to be. Do you just want to have a time where we get together? Do you want to go out and advocate? Do you want a sober dorm? Let's go talk to the dean. They're creating their own identity.
Amazing.
As to what this can be. So, continue to look into what this awesome new infrastructure is that is emerging, to find out what can attract and engage you, particularly as a professional,
Absolutely.
as a peer, whether it be a peer or because you want to learn another route. There's places for a lot of different people to have a seat at the table now.
Yeah, absolutely. And this one is maybe a little bit harder of a question. You mentioned folks with a lot of medical mistrust, and I know that is very prevalent in communities that have been marginalized for a very long time.
Right.
And as someone who works, you said you worked in a hospital. How would you address some of that medical mistrust in terms of entering this recovery sphere, and being involved and having a seat at the table?
Yeah, I tell you what, you got to learn to have a credible conversation with communities of color. Two things I think start to need to occur is one, you're going to have to address that there is medical mistrust and how that medical mistrust happened. We can't ignore the elephant in the room. We have medicine itself has a history of medical misinformation regarding race.
Yes.
And we still have that problem. Okay. We still have that problem. We have a very recent study coming out of the University of Virginia, interviewing about 92 doctors and doctors in training, medical school, early residents, and they're finding that their perceptions of pain, right? Pain is closely linked to our field sometimes, right? And it's also there's similar medications sometimes, but who believe that because of there was biological difference with Black patients and white patients, it's affecting their perceptions of pain. We've got a really important study uncovering that doctors believe that Black people's blood coagulates at different rates, that they believe their skin was thicker than white individuals, right? And so we will work to provide racial literacy to our doctors in training in order to do that. But you've got to be able to acknowledge that to the Black community. The Black community is familiar with Tuskegee.
Right.
They're familiar with our Black history. Their entire books written, and for those of us who don't want to read the books, you can watch a Netflix movie, because they will reenact the scientific abuses that have been done on this community and continue to re-educate the next generation. So you have to be able to address, there's been medical mistrust. We haven't always gotten it right, okay? But we're here to do better.
Yes.
But we're here to do better. So you're not going to build trust by ignoring the elephant in the room. Furthermore, you're going to need to work with some of their stakeholders and their gatekeepers. Right now, we're learning that we want to work with the faith community, congregation leaders, okay?
Sure.
Because it is science. The research has shown the role of spirituality and religiosity is highest in the Black community, and I'm still talking about the recovery community.
Sure.
Amongst people in recovery, it's highest in that community. You need to learn to work with their gatekeepers and help them understand not only what it is we're doing, but you need to get to understand them and find out where they're comfortable helping.
Yeah.
Because I've learned that when I talk to them about whether it be prevention, treatment, let them know recovery has a seat at the table they might be interested in. You have to find where they're comfortable working at in order to access the community too, right? Yeah. So you can't ignore the medical mistrust and the missteps that have happened along the way, right? Even in our own medication with healthcare, with opioid use disorder right now, we know Black people on average are getting smaller dosages for shorter durations. Right. So, but you're going to have to be able to call that out, say that we're aware that it's happening. We want to do better. And furthermore, work with their stakeholders to gain trust into this community,
right,
and to listen to what it is that they're okay with and what they're not okay with. Find where they're comfortable.
And to bridge that into the conversation we were having earlier, how does that medical mistrust show up in recovery community centers? Or is that something that is a specific strength to those recovery community centers?
Yeah, I can tell you, we are definitely one of the strengths that we're hoping, and over time we'll learn and we'll see. One of the things that we're hoping is that by having these organizations that work within people's communities, and they're not necessarily led by clinicians. They're often non-clinical. And so we're not leading with medical mistrust. Right? We're certainly not leading with the criminal justice system, and we're not leading with medical mistrust. We're leading with peers. And by doing that, we're hoping that we can build trust there. Kind of sidestep some of the issues that have happened in healthcare. We're not saying you have to go to healthcare to work with this recovery community center.
Sure.
And so peers is a way of gaining access to people that maybe we've broken the trust through other ways.
Yeah, that makes a lot of sense.
Yeah.
That makes a lot of sense. It's kind of beautiful to hear about that very specific strength in this newly emerging kind of system of care.
And there's just this study, it's not necessarily been published because I just saw it presented at a conference called CORES that we do at the Recovery Research Institute, and it got an award for a poster. So it's very early and preliminary data.
Cool.
But one of the things that they found was when, people often ask me and they want to know, I want to work in the community, but I only have so much staff that's somebody of color. What does that mean, right? We don't always look like the people we want to help, right? Does that mean I can't do it, or what? This very interesting poster that was recently presented at CORES was finding that the priorities, though, when matching people, it was less about if they had to be racially concordant and things like that. It was more about the person's recovery time and things about that. That's where they were bonding on. Cool. The coach versus the person who they were working with.
Yeah.
Right. Yeah. So you aren't always going to, and you're not always going to look like the people you serve, but we've got other factors in recovery that are bonding people together and working together.
Right?
Exactly.
Yeah,
exactly.
Absolutely.
Yeah.
That's fantastic. So, for you, that sounds very exciting. I would love to do more research on that, or to learn more about that once it is published.
Once it's published, that's right. We need that. Yeah.
So, as we kind of start to approach time, I'm curious, what are some of the things that you in your work are excited for? What are you looking micro and macro?
Yeah, absolutely. I would love to help to continue to build the recovery science agenda regarding health equity. We have a lot of unanswered questions in our recovery field, and we could take a page out of the playbook of treatment.
Sure.
We've learned certain things by researching this field, front and back. Sure. We've broken down questions regarding, all right, do people have access to certain things? We do geographical studies to see if they have access to different modalities of treatment. We then see if they're utilizing them or not. That indicates different barriers, right? So when you're trying to reduce barriers, we want to see if they're utilizing them. And then if they do get in, are they retained at the same rate? And then, of course, there's efficacy. We want to learn about the outcomes. We got a whole recovery ecosystem that we could serve to answer those questions. Do people, let's looking on a national level and a state level, do people have access to recovery support services, housing, recovery community centers, right? All of these things that are emerging. Are they using them? Yes or no? And if not, why not, right? And then when they do use them, are they staying in or are they leaving early, right? Is there differences there? And then are they working the same for everybody?
Sure.
Those are a lot of those across all those recovery support services are unanswered questions, right? And so we can certainly forward that agenda of working with making sure that we want recovery for all. We don't want anybody left behind. And those are just a few of the unanswered questions that we have. I also think that there's important questions that lie at the intersection of treatment and recovery support services that we don't have answered yet. We know that AA is more effective than even some frontline treatments at producing continuous abstinence rates of alcohol.
Sure.
But we knew that because we tested them together in studies.
Sure.
But right now we have recovery support service studies happening over here and clinical trials of medicine happening over here. Recovery housing is something that I'll point out that shows very strong effect sizes.
Yeah.
It's even being trialed for people with opioid use disorder alone, right? But we want to have pathways to recovery for people. And so if I, as a provider, doesn't matter if it's peer or clinician, if I want to be able to provide pathways to recovery, I want to be able to say to them, hey, if you take the medication, it can help your chances of remission by about 40%. If you go to the recovery house, that could help your chances of remission by maybe about 30%. That's how you present pathways to recovery.
Yes.
But until you start putting them in the same clinical trial, let us see what the effect sizes are so we can provide the information to our patients so they can make decisions about what it is that they're willing to engage with, and we can give them the information that they need. So there's a gap in our science there that I think that we can better serve people.
Sure.
If we understand the intersection of these services and offer more pathways to recovery that we know are evidence-based and that has an increased likelihood of benefiting people.
Sure. Sure. That's phenomenal. That is hope. That sounds like hope to me.
Yeah.
That sounds and excitement. This future could be really bright. And with folks like you working on it, I have no doubt. So, Dr. Vilsaint, we have one last question that we end every podcast with. What's one piece of advice for our listeners at home?
Oh, one piece of advice is, I would say that the hope of recovery. The hope of recovery is there. We've captured this in our studies. We watch people, but we've also learned to capture this in our study. You got to know that it's about 70% of people are going to be able to recover from this disorder, okay?
Yes.
Right, like 70% of people are going to recover. This is a good prognosis situation for many people. And I think that if I had to leave people with one understanding of recovery, I think that that's one of the most important things that you need to understand.
Yeah.
So keep fighting the good fight.
Absolutely.
Yeah.
Thank you so much for joining us. This was a wonderful conversation.
Thank you so much for having me, Oliver.
Thanks for listening to Recovery Stories Have Power. You can listen to all of our 2 seasons at pod.facesandvoicesofrecovery.org. And a huge thank you to Dr. Vilsaint. We've got one more episode coming at you, so stay tuned. We release new episodes twice a month, once in the middle, once at the end, always on a Thursday. Produced and engineered by me, Oliver Books. Video, technical support, and website by Chris Aram. Opening and closing music is Come On Home by our friend Chris Tate, and shout out to the good folks at his RCO, Passenger Recovery. Comments or questions, send us an email, podcast@facesandvoicesofrecovery.org. Don't forget to rate and subscribe, and thank you so much for listening. We'll see you next time.